With us today is Dr. Andrew Gonzalez. He's a health services research fellow at the University of Michigan. He's also a resident physician in general surgery at the University of Illinois Hospital and Health Sciences System. Remember, everything he says here today is his personal opinion, doesn't necessarily represent any of the organizations he's associated with. Dr. Gonzalez, we had this article, and actually NPR did a piece about it, and the New York Times did a piece about it, which talked about how Medicare put out its hospital level charges, and it turns out that the same procedures at different hospitals for different people are often charged differently. Now, of course, number one is I think we should differentiate between the amount that a hospital bills and the amount that Medicare pays. So just to kind of get us up to speed on that, summarize the findings for us.
So the findings of that article and the recent release of data from Medicare found that there's wide variation in hospital charges between health systems across geographies, et cetera. So as you mentioned, the things that are important to consider is there's three components of hospital billing. There's one, the charge, which is how much the hospital would like to receive in an ideal world. There's cost, which is how much resources went into taking care of a particular patient. And then there's payments, which is how much Medicare or third-party payer actually compensated the hospital. These values are almost never the same.
Right. So, for example, in Hartford, Connecticut, there was, which is, by the way, the health insurance capital of the U.S., one of the larger hospitals charged a little over $15,000 to treat a Medicare patient that had chest pain, and they actually received just under $5,000 for the service. So although they tried to receive $15,000, they received less than a third of that. Nearby, a smaller hospital in Torrington, Connecticut, charged Medicare about $7,000 and received $3,700. So the difference in charges seems to be far more drastic than the difference in payment. But that being said, there are payment differences as well. How are those explained?
Right. So with Medicare, it's a little bit different than with the majority of private insurance companies because Medicare has a kind of standard DRG or diagnostic related group payment that it applies to everyone. So the Medicare actual payments will probably be not as different as private insurance. So once Medicare decides what they want to pay for a particular DRG, there's different adjustments that go into the mix. For instance, they use something called the disproportionate share payment. So hospitals that take care of a lot of uninsured patients get a slight bump up. There's a cost of living adjustment. There's a teaching institution adjustment, and those things may raise or lower the amount compensated by Medicare. As far as private insurance goes, the charges, the way you can think of that is kind of where the bargaining begins.
This is really disproportionately not good for uninsured people, is it not? In the sense that it's kind of like if you go and you go to buy a car, there's a sticker price on the car. And if you don't have any negotiating power, you're going to pay pretty close to that sticker price. In the same sense that whatever the hospital wants to bill, insurance companies know the game, they have bargaining power, and they're not going to pay anywhere close to that. If you have no insurance, you get a bill from the hospital. It's the $15,000, for example, instead of the $5,000. You have no bargaining power. Uninsured people are disproportionately affected by this discrepancy between charges and actual payments, are they not?
Absolutely, they are. There's actually some good reviews on a blog that I blog for, policyprescriptions.org. And basically the issue here, well, there's two issues. One is whether or not people who don't have insurance actually end up paying these amounts. And then the second is the theoretical issue of the charge. So regarding the latter, that is definitely true. It's unfortunately capitalism at work. People who don't have bargaining power can't go and bargain with the insurance companies. However, in terms of actual payments, i.e. how much does it matter to the taxpayer, how much does it matter to health systems, a lot of care that's given to uninsured or the quote self-insured patients is actually uncompensated by the hospital. So the charge issue is very, it doesn't necessarily matter as much as one might think in the real world. The other issue is that, yes, you have lots of bargaining power, but many or less bargaining power, but many people who are uninsured don't attempt to bargain.
Well, I was
There's a
going to
lot.
ask you about that. So before you talk about that, let me actually, it's great that you're bringing that up. I've done some reading about this, and I've read anecdotally that sometimes people will say, for example, a family of four loses their job. They want to keep the same doctor. They'll go to the doctor, and it may be probably more common at solo practices or small medical groups, and say, listen, I would like to keep you as our family doctor. What kind of deal can we make for continuing to see my spouse and our two kids? Could we say that even though what gets billed to insurance for office visits is $275, that you'll see us here for $125, but we'll pay you out of pocket so you save money having to bill insurance, etc.? Are those types of deals common? Are they possible? Talk about that a little bit.
Sure. It's really difficult to know how common they are because these data points don't necessarily exist for someone like me in health services research. But as far as that goes, again, if you're negotiating with a large healthcare system, it's difficult to walk into a, large vertically integrated hospital system that has dozens of hospitals and say, hey, I don't want to pay X, Y, and Z. Now, if you're talking about just primary care appointments with like a family physician or a private practitioner, that's a little bit easier to do. And if you haven't attempted to negotiate, I would encourage you to negotiate.
For people with employer-based insurance, is there any negotiating to be done, or is it just you pay your copay and that's, the insurance you carry has basically done the negotiating for you?
By and large, that is the case. However, as far as employer-based insurance goes, unfortunately, a lot of people don't check their bill because you pay your copay and that's kind of it. You don't really investigate, like, why is it that the pill container costs, $300? So generally speaking, the beneficiary doesn't look, and a lot of times neither do the insurance companies because they're kind of negotiated the rate. But this is still nonetheless an issue for everybody because a lot of people who have to declare the medical bankruptcy happens because they've exhausted their insurance benefits. So even though they had employer insurance, once you exhaust your benefits, largely because of like inpatient stays or major surgery that had a protracted course, then you are, for all intents and purposes, uninsured.
Right, so it's important to check what's being billed to the insurance, even if your copayment isn't necessarily affected by that. We've been speaking with Dr. Andrew Gonzalez. Dr. Andrew Gonzalez has agreed to answer some of your medical questions, so please leave them on our voicemail line, 219-2-DAVID-P. In a couple of weeks, Dr. Gonzalez will be back. We'll take some of the more interesting questions, and we'll get Dr. Gonzalez's take on those. So again, call our voicemail line anytime, 219-2-DAVID-P. And remember, Dr. Andrew Gonzalez's opinions today are his own and not representative of any of the organizations he's associated with. Doctor, thanks again for being here today.
Thank you so much.